Hello, I'm Llewellyn King, the host of MECFSAlert. This is coming to you from Brigham and Women's Hospital in Boston, where we're going to be talking to Dr. David Systrom, who has some absolutely extraordinary things to say about medicine, research, and his work in the field of ME. I would like to thank my co-host in this program, Deborah Woroff, for her assistance with research and her general support of the program. If it were not for her, it would not be on the air. David, welcome to the broadcast. Would you like to explain your position and your medical qualifications, if you will, so we all know clearly who you are and I don't have to paraphrase it?
Sure, Llewellyn, and thank you for the invitation to do this interview. So I'm a pulmonary and critical care trained physician. My training was at Dartmouth Medical School in Hanover, New Hampshire, followed by an internal medicine residency at Emory University Hospitals in Atlanta, and then a pulmonary and critical care fellowship at Mass General Hospital and Harvard Medical School. I remained on faculty for 28 years at Mass General Hospital and then came over here to the Brigham about 6 years ago to do some of what we're going to talk about here. My specialty, subspecialty as it were, and my research interests focus on exercise intolerance, and that's all forms of exercise intolerance, everything from shortness of breath, also known as dyspnea, to fatigue, to orthostatic lightheadedness, intolerance in the upright position. Along the way back in the day, I was asked to head up a very special exercise lab at MGH. It was called an invasive cardiopulmonary exercise lab. And initially it was built by cardiologist Jerry Pohost and pulmonologist David Kanarek, two of the greats in internal medicine who preceded me. And it was designed to ferret out reasons for exercise intolerance that weren't readily explained by tests done with the patient at rest. It was designed to determine whether there were diseases that could be detected in a sensitive fashion very early on, perhaps, or the subtle forms of the disease before they were full blown. And initially it was really focused on heart and lung disease. And then over the years, with various referral patterns, both physicians and ultimately, these days of social media, self-referrals by patients, we came to discover that there are many, many patients out there with all forms of exercise intolerance, and by that I mean shortness of breath, fatigue, and lightheadedness alone or in combination, who don't have any heart or lung disease. And it's something else. And that something else has led me to this ME-CFS journey.
That's very interesting because, first of all, let me make the point, you are a practicing physician. You are not purely a researcher. You see patients. Indeed, before this interview, you were with a patient, and it's very nice of you to take the time to be with us. You know, it's largely viewed, the doctors have a very simple prescription for everything. Diet and exercise. Diet and exercise is a sort of rather boring repetition, but in fact that is not always the solution, is it?
No, it isn't, although I wouldn't minimize the importance of both of those things. And in fact, when we do find diseases that we treat, for instance, with medication, part of our prescription will also include an exercise prescription modified according to the patient's disorder or disease.
Now, there's been a lot of controversy in myalgic encephalomyelitis over exercise and the intolerance to exercise, and particularly there was what's very close to a scandal in England on this very subject of the so-called PACE studies, which I'm sure you're familiar with, where exercise was probably over-relied on.
That's correct. So we believe that the disorders that we see that are often labeled by referring physicians as MECFS have as part of the disorder elements of detraining that might be partially responsive to exercise, but we also fully recognize that overuse of exercise, and our patients are the first to tell us that they'll suffer from post-exertional malaise a day or two later, and that too much exercise may not be a good thing for a variety of diseases, including MECFS. And the proper exercise prescription, I think, is evolving. It is part of our research, determining what type of exercise, how much, what form of exercise should be used is a very important part of what we're doing currently. At MGH and then more recently here at the Brigham, what my colleagues and I have done, and I should emphasize there's a small village associated with me, and I'm very grateful for all of their help. Everyone from MD, PhDs working in the basic lab, to other clinicians working with me, to our physicians' assistants, our exercise physiologists. We've assembled a small village, and we have what's called here at the Brigham a dyspnea clinic, but it's increasingly a terrible term, and we're probably going to have to change the sign over the door. There is no sign over the door, but the virtual sign. It is really an exertional intolerance assessment center, as it were. And we have people from cardiology, rheumatology, immunology, neurology, from all walks of life kind of collaborating and helping us out. But at the centerpiece is what we call a dyspnea center, and it's where we initially see our patients with under or unexplained exertional intolerance. We'll do the time-honored history, physical exam, laboratory values. When appropriate, we will do chest imaging, we'll do cardiac stress testing if it's appropriate. These days, most patients don't pass go without a cardiac echo with a full set of pulmonary function tests. And we make certain that there is not something readily apparent before we get to the exercise testing. And then sometimes we'll start with non-invasive exercise testing, but about a third to 40% of our patients seen for exercise intolerance of uncertain etiology or reason end up undergoing what we call an invasive cardiopulmonary exercise test. And this is, in our world, a cycling exercise test. It's incremental. It takes about 6 to 8 minutes to do. It's a bit of prep time, about an hour, and a bit of recovery time, about an hour. And in between, in the middle of all of that, a little cycling exercise with a mouthpiece in place, nose clips on, EKG leads, a pulse oximeter, and the patient pedals away to exhaustion, although the time spent at intense exercise is measured in a minute or two, and most patients rebound quite quickly. What makes our test both invasive but also very special, and what enables us to really peer into the interior of the organism, as it were, and determine what is wrong with the patient, is 2 catheters go in place. And I have a couple of interventional colleagues who do this in the cardiac cath lab here at the Brigham, Aaron Waxman, Sasha Opatowski. They are incredibly good and quick and fast and safe. And they put these 2 catheters in, one in the radial artery in the wrist, and the other in the internal jugular vein, and it's called a pulmonary artery catheter. The latter is a long catheter. It's advanced by flow, a little balloon at the end, downstream as it were, and it's the tip of the catheter comes to reside in the pulmonary artery. That positioning is the heart and soul of this test, and it enables us to do 2 things. We sample blood from the distal pulmonary artery port and from the radial artery for blood gases, so oxygen content, carbon dioxide, pH, and lactate. And a variety of biomarkers, and this will get into the research that we're currently doing in an effort to determine signatures that indicate this disease or that in the plasma of the patient. So blood sampling occurs at rest, every minute during exercise, at peak exercise, and then 1 hour after the recovery from exercise. Additionally, we're measuring pressures, and in a second I'll tell you how we use these to determine what ails a patient with MECFS. The pressures are measured at several different ports along the long pulmonary artery catheter and from the radial artery catheter where we get blood pressures. The distal tip of the pulmonary artery catheter, we can determine whether there's any pulmonary hypertension. That is not something that's very prevalent in MECFS. We can determine whether there's any evidence of exercise-induced heart failure. That's prevalent perhaps in older patients, sometimes with fatigue and shortness of breath. It's called heart failure preserved ejection fraction, and there's a variety that we can diagnose that's just apparent during exercise, not at rest. Without the exercise, we don't see the pressures elevated as a function of the left heart not relaxing. But what is ubiquitous with patients in our hands, given the clinical diagnosis of MECFS, is something that we call internally preload failure. What we see is an inability or an unwillingness of the big veins in the legs and in the abdomen and the pelvis to squeeze down and physically push blood up to the right heart to prime the pump, as it were. So the hallmark with exercise testing in our hands of MECFS, it's almost always present, is low filling pressures of the right heart, inadequate filling pressures, and that does drive some of our therapy. The additional thing that we see, and this is less with pressures and more with systemic oxygen exchange or extraction, is in abnormality of systemic oxygen utilization and uptake by the exercising skeletal muscles. So in the radial artery catheter, we have arterial oxygen content going out to the muscle. The distal tip of this pulmonary artery catheter, when we pull back our blood samples, amongst other things, we get the oxygen content in the mixed venous blood, which really, especially at peak exercise, reflects the ability of the human to get the blood out to the muscle and then redirect it within the muscle at the microcirculatory level to where the slow twitch mitochondrial-laden muscle fibers are. And if all that machinery is running properly, we will see a reflection of full oxygen uptake coming back to the distal tip of the pulmonary artery catheter at peak exercise. And the difference between arterial oxygen content and mixed venous oxygen content will widen normally, especially at peak exercise. The vast majority of patients with the clinical diagnosis of MECFS in our hands, additionally, in addition to the preload failure problem, the failure to prime the pump with pressure and blood volume, they additionally have a problem with systemic oxygen extraction. It appears that the muscle is not taking up oxygen normally. This is an area of our research and intense interest. The differential diagnosis of impaired oxygen extraction at peak exercise is vascular dysregulation, which we suspect is the case in many of these patients with MECFS. But it also could be due to intrinsic mitochondrial dysfunction in the limb skeletal muscle. So the machinery is not operating normally in the muscle mitochondria, and it doesn't sop up or take up the oxygen normally. And we are intensively pursuing that differential diagnosis.
Is this a different approach to other people who are looking at T cells and possibly Epstein-Barr virus, maybe at different viruses that are resident in the body anyway?
Yes, Llewellyn, I think it's fairly put it as a different approach, but I might emphasize it's a complementary approach. So none of these things is mutually exclusive. It is biologically plausible that the root cause of many patients' problems that we document physiologically could be chronic viral infection. And what we, and perhaps this is a good time to get into this, what we have discovered is that there is both historically, many of our patients come to us with a sentinel moment in life, and I'm sure you've heard this one before. Doc, I was fine till I got the flu 5 years ago.
They remember exactly. There's no other disease that people so accurately know the moment of onset.
Exactly.
And record it, as it were.
Right. So we believe that there is not only that interesting history, but it probably does beget a biologically plausible sequence of events where you have some form of host susceptibility, whether that's genetic or acquired or epigenetic, we don't know. And then there is one of these traumatic moments, to use a loose term, often a viral syndrome, but not always. Sometimes a bacterial infection, sometimes trauma, and I have even heard severe psychologic trauma.
Don't we have empirical evidence that all three of these are in fact valid? Because we've had outbreaks in clusters, which suggest an epidemic, but most people are individual, and many associate their outbreaks with exercise, not all, but with exercise. Many of them were athletes, usually in their teens. They were athletes, very athletic people who suddenly couldn't do it anymore.
Exactly right. And then what transpires is a very classic history of a combination of fatigue and post-exertional malaise is obviously a feature. For us as pulmonary and critical care physicians, we see a lot of patients presenting additionally with shortness of breath, which can be a component of it, and whose mechanisms we're also investigating, and then lightheadedness, either postural or with exercise. All those seem to run with each other. And then we can reproduce many of those symptoms acutely during this exercise test.
Why do you believe some patients are acutely sensitive to light, to sound, even to touch?
Right.
And others do not have that sensitivity at all. And why do some have joint pain and others do not?
All incredibly good and important questions. I can give you a little bit of insight, perhaps, and it's still at the level of hypothesis from our own work, though, and that of a close collaborator over at Mass General, Dr. Ann Louise Oaklander, who's a wonderful neuroimmunologist with a subspecialty in something called the small fiber polyneuropathy. So Ann Louise developed an FDA-approved skin biopsy, which we are now doing in all of our patients we identify with this exercise phenotype. The skin biopsy is specially stained, and 3 weeks later we learn what the neurite density is in the epidermis. This small fiber polyneuropathy classically has been described in diseases such as fibromyalgia. It's 40% prevalent in that disease. It has a 40% prevalence in postural orthostatic tachycardia syndrome. And the new news, and you heard it here first, Llewellyn, is that we have data that suggests that at least 40%, probably closer to half of our patients with MECFS and this preload failure pattern on exercise testing also have a small fiber polyneuropathy by skin biopsy. And the anatomy is now married to the physiology. And what we know about the small fibers is that they are ubiquitous. They're probably a primitive part of our peripheral neurologic system. They're involved in pain, and when they are misfiring, it begets what we call loosely neuropathic pain, but also associated with arthralgias and musculoskeletal pain. Now, we find the classic distal symmetric small fiber polyneuropathy, in answer to your original question, in only half of our patients. So maybe, and we're working on this,
that would also be the link to fibromyalgia.
Yes, and the overlap and POTS, postural orthostatic tachycardia syndrome. It would be one anatomic link. So what we know about the small fibers is they are intimately related. In fact, they are nociceptive fibers, unmyelinated fibers, the C fibers, but they also, and this has been underappreciated, are very important in autonomic nervous system function. And we believe that one potential pathway to everything that we're seeing, MECFS, the clinical syndrome, the preload failure that we document on our invasive exercise test, the failure of oxygen extraction in those very same patients. All could be mediated by dysfunctional autonomic nervous system, in particular an imbalance between sympathetic and cholinergic or parasympathetic autonomic nervous system function.
I have found that most doctors or researchers in the field came to it because they knew somebody who was suffering. But you came to it through pure science, right? You came to it because you were studying fatigue.
That's accurate, yes.
And there you found a whole disease that, as it were, is devoted to fatigue, or its principal manifestation, its terrible manifestation, I don't want to make light of this at all,
no.
is fatigue, lifetime fatigue.
It is, everything you said is true, and what I have found really over the past 3 to 4 years, as our referral patterns have changed, as we've achieved a little bit of notoriety here at the Brigham for making specific diagnoses in patients who've been written off, as it were, by the medical system, told that this was in their head, told that there's nothing wrong with them. I've developed an appreciation and actually a little bit of anger at the medical community, the uninitiated, who don't know that this is in fact a real disease and that we have treatments. So I'll give you a little bit of an anecdote, but it's really not one. I see this frequently. I will see a patient in the dyspnea clinic here at the Brigham. We will do the testing on them. We've actually written a paper on this. It's published, and I can forward it to you if you wish. The amount of time that a patient has had symptoms and gone undiagnosed, on average when we see them, is 3 to 5 years. And the amount of healthcare dollars spent on them, oftentimes wastefully and going down the wrong road, is phenomenally high. Many patients have had millions of dollars spent on them of scarce healthcare dollars, and without any answer. And they may have seen, not to name names, a certain specialist who has ordered whatever in their specialty or subspecialty standard therapy, no answer, and then they're back in a year without any answer and without any treatment, the same symptoms or perhaps worse, and then the same tests are ordered over again. So we've seen patient frustration and a lot of medical care provider frustration going both ways. They're all frustrated because they don't have answers.
What have you found helpful to patients? And is it a case of several therapies or a single therapy? Have you found, for example, any compound like Ampligen that helps?
Yeah, we have, and this has been a bit empiric, but it's also based on science. I should also say that we are about to launch a double-blind, placebo-controlled prospective study. We found funding to do so with our go-to medication, at least at the moment, which is pyridostigmine, mestinon. And I should hasten to add, this is off-label use of an FDA-approved drug. And it is frequently used.
Like Rituxan B is an off-label use.
Exactly, right. So pyridostigmine has been around for 50 years. It's FDA approved for the treatment of myasthenia gravis. Myasthenia gravis is an autoimmune disease where antibodies attack and crowd the acetylcholine receptor at the junction between the peripheral motor nerve and the end plate of the muscle and the limb skeletal muscle. And patients present usually with weakness, but sometimes bulbar symptoms as well. The mestinon or pyridostigmine drug prevents the breakdown or retards the breakdown of acetylcholine, therefore promoting the buildup of acetylcholine at the synapse, and improves myasthenia gravis. We think, and we've had a lot of luck with this, and have treated about 300, mostly women, with MECFS, and have objective evidence and subjective, but also objective exercise, non-invasive exercise evidence that they get better, the vast majority of them. We think the way it works, and this is what we're looking to prove, is probably twofold. It promotes the interaction, the healthy interaction between dysfunctional autonomic nervous system and the vascular bed. And that's both, we think, on the venous side, where we promote venous constriction and that preload failure that I mentioned earlier, but we also have evidence that it favorably affects the vascular distribution of cardiac output out to the limb skeletal muscle, and in particular the slow twitch muscle fibers where the mitochondria are. So we think it's much of the beneficial effect of pyridostigmine has to do with favorable vascular regulation. Now, there's probably more to it because it is a parasympathetic drug, and enhancing the parasympathetic arm of the autonomic nervous system also may have favorable anti-inflammatory effects and may actually favorably affect the immune system. So the interaction between or among autonomic nervous system inflammation and autoimmunity is a fascinating area. There's huge overlap. We think of that Venn diagram, and that's something that we're actively pursuing.
You mentioned the shortage of dollars for healthcare. The shortage of dollars for research is even more acute. What do you think? How do you think we should deploy these dollars? There has been a quickening at the pace. In the last 2 years, there's been more money, more interest, more sense that this is a race that can be won, although nobody knows where the winning post is. Given that, how do you think we should be deploying research dollars?
Right. Well, I'm very much aware that the NIH has just awarded a big grant to Stanford and MECFS, and I think that's a wonderful first step. I think the big picture, I mean, the initial step was getting the National Institutes of Health to recognize the scope of the problem, how many patients are affected, how many healthcare dollars are wasted in attempting to diagnose them. And then I would turn to large centers with expertise. And in a sense, it's an odd disease in that this is not strictly coronary disease, just to name a disease. It's not a pulmonary embolism. That's pretty simple. Coagulation abnormalities meet the pulmonary circulation. It's such a complex disease with so many facets that this has to be multi-center in nature. It has to be multidisciplinary in nature, and everyone has to talk to each other. And by that I mean neurology needs to be talking to cardiology and pulmonary and rheumatology, all in the same room. And that's what I tell the center to do, to make big awards for center grants that are multidisciplinary with all the components of expertise that we need, but to help facilitate the crosstalk.
That is what has been discovered in engineering, is that multidisciplinary is essential. I like to use the example of the jet aeroplane. When metallurgists reached as far as they could with temperatures in the combustion chamber, couldn't get it any hotter, couldn't make a metal that would stand the heat. The fluid dynamicists said, no problem, we'll just have a little channel here, a little flow through there. And the ceramicists said, well, we'll put an edge on this. This can be done, and it is known, but it's not always done in medicine, where there is a tendency for specialists to lower the portcullis around their specialty.
One can imagine that that's natural. One does what is in one's wheelhouse. And it's like herding cats on occasion. And sometimes there has to be a strong force from above to break down silos and to do exactly that. We've done that here at the Brigham. We've done that with our dyspnea clinic. We've done this with this invasive cardiopulmonary exercise test. And just recently, you may be aware, Llewellyn, that Dr. Tompkins over at MGH has announced the establishment of Harvard Chronic Fatigue Center. We are going to be an integral part of that, along with others, including Dr. Oaklander and Dr. Amel Kara, world-class mitochondrial geneticist at MGH. So this is a wonderful step here in Boston, and I know the preliminary word has gone out and pleased many of our patients and patient advocates for MECFS.
This has been an extraordinary conversation, and I'm very grateful. What do you say to the person who calls me because they've seen these broadcasts and they're in South Dakota or somewhere? They cannot find a doctor, or they've been misprescribed and they're going through the whole family trauma of you're just lazy, it's been 6 months when you're going to get out of bed and go to work. All of that horror, that terrible horror that this disease brings with it. What do you say to those who are far from Boston with its plethora of hospitals, specialists, and care available? Is there any sort of national way that people can get in touch, even if it is only to call you on the phone or somebody like you on the phone?
Sure. Well, I think this is where the foundations are way out ahead of places like the NIH and even our own government. I think the foundations have lists of doctors with local expertise. I'm thinking of an analogous situation for a group that I've participated in called Dysautonomia International. They have a website, and there's a lot of overlap, as I said, with things like postural orthostatic tachycardia syndrome. And anybody in any state, in fact it's global, in any country can go on this website and see docs who have put their hand up to say, we've got expertise in this and we're here to help.
David, it has been wonderful talking to you. Thank you so much. I hope we can come back.
Oh, thank you, Llewellyn. I'd love to report back on some of our progress in the future.
We will do it.